Okay, guys, well, welcome to tonight's session with myself, Steve. I know quite a few of you will have been on these sessions beforehand, and obviously kind of know the format really. Welcome to you guys, welcome back, and welcome to people who are new who've never been before. I know some of the students from the university that I teach at have kind of rolled in, so they'll be dripping in as well, which is great. What I'll do is I'll do a quick little intro, guys, in terms of kind of what the evening is going to look like. And then what I'll do is we'll kick off into some of the content. So there's a lot of videos that I've kind of pre-recorded, me going through assessments and treatment techniques, which obviously I can't do from my own living room. So what I'll do is I'll play that for you. We'll break off, have a little bit of a Q&A, but there's loads of really nice bits in here that hopefully you guys can utilize in your practice or kind of add to your little mixture of things that you're doing. So this is me. I'm more kind of interested in what you guys are up to. So if you can just add your name, your details of what you kind of are doing at the moment. It might be that you're a student. It might be that you're working in sport already. You might be in NHS worlds. You might be private practice. You might not be doing anything and kind of using this as a little bolster to try and get you into the mix, really. But this is my background. I've worked at a few different places across my career, mainly in sort of elite rugby for about 10 to 12 years, and then sort of more recently in Olympic Games, Paralympic Games, Commonwealth Games and things like that, really. So a nice little mixture. Be very careful where you decide to work, because you will get a lot of ACLs in rugby, in judo, martial arts, places like that, places where I've generally tended to work. So I have come across quite a few of these. And then one of my big passions that I'll kind of go through is obviously teaching, sharing some of the lessons that I've learned from working in and around these worlds on the Grow Physio platform and at UCB in the bottom right there. So as a lot of you know, what I generally tend to do is share some content from the Grow Physio platform every month. You'll see the list on the right-hand side. So this month, we've actually got a double whammy because the ACL is pretty complex. So we've got today's session looking at assessment and treatment techniques. And then what we have next week are the sort of the rehab components. So if you want to see how we translate the assessment, diagnosis, and treatment bits into a rehab program, that might be really nice for you to kind of jump on next week and have a little look at that. But you'll sort of see over the course of the year, we've got hamstrings next month, and then we go into some of the pitch side management as well. So we've got acute injuries, be it MSK, concussions. We've got the unconscious athlete and how you manage those, and spinal related injuries. Basically things that will help build your confidence working in and around athletes, sports, and you'll sort of see over the course of the year, as I say, we kind of work our way up the body, up to the shoulder by the end of it. So you hopefully by the end, you end up with a pretty good idea in terms of what to do with various different injuries. They're all built on the Grow Physio Academy platform. So you can dive in there. I know there's quite a few members that are jumping on here tonight who are already members, who are kind of interacting in that community, benefiting from some of the other kind of online support that we have. But this is tonight's session. As I say, the ACL is a pretty commonly talked about little tiny body part, isn't it, really, that kind of causes massive havoc, changes people's lives, turns everything upside down for both the therapists, the athletes. Lots of debates around the management, the optimal kind of return to play guidelines. But yeah, we'll go through the initial stages to start with. So I'm going to play you the first part, which again is sort of that understanding of what that ACL does, how it gets injured. We've got loads of lovely videos on how it potentially becomes ruptured. Some of them might be a little bit more surprising than others. I think I used to always think it's bound to be a massive collision or an impact that causes it, but the vast majority of them are actually sort of non-contact injuries. Well, I'll then jump back on again, and if you've got any questions, any queries, anything that you want to ask about anything, then you can do that. And then once we've kind of wrapped that bit up, I'll play you the second bit. Again, that's me in the clinical environment, going through loads of the treatment techniques, taping strategies, manual handling, therapy, mobilizations, things like that. And then I'll jump back on again. And if anyone's got any queries, then obviously very happy to answer them as well. So yeah, it does come from the Grow Physio Academy, which was something that I set up very much for the reason I've had about 3 emails this week asking Pete if I can kind of take students on for shadowing opportunities, and unfortunately, you just can't invite everybody in. So this is my answer to it, so people can dive on this, almost have that sort of immersed experience within an elite setting and see what goes on without having to necessarily have to be best friends with the manager or the one of the key players or something like that. It's a great platform that's kind of grown over time. It does help people move into careers within sports. So there's been loads of people, really inspiring stories of people who kind of really wanted to go into it, not kind of been loving life necessarily in NHS worlds, and then kind of almost stepped into academies and sports roles, which has been a bit of a dream. And all these webinars are included. It includes mentoring sort of support sessions every month that we call a team huddle. And there's loads of different exercise examples and things from there. So yeah, it's all just broken down into different courses if you're interested. So if there's anything on there that you sort of feel like, well, I wouldn't mind upskilling in, it does go through a similar format for each body part. So it'll go through the theory and assessment, the treatment, the rehab, and then that sort of return to play, with a few differences in terms of that kind of pitch side course, injury reduction courses, and athlete sort of testing courses are there as well. All of this will be recorded, guys. So I'll upload this to a private YouTube link and send it to you. You've got up to 31 days, so a full month, to kind of review that as many times as you wish. I appreciate lots of things come thick and fast, and you might want to practice some of the tapes, maybe taping techniques or something while I'm there. So you've got plenty of time to do that. And I'll also include your certificate. So you'll also get this. Just make sure if it hasn't landed in your inbox tonight that you just check your junk mail, because it will be in there at the email that you guys registered for on Eventbrite. That's just my socials and website. So it's growphysioacademy.com, or have a dive on kind of Instagram or LinkedIn. I'm usually a little bit more active on. So without further ado, again, a massively sort of warm welcome to people who kind of introduce themselves on there. Oscar, Jody, Everett. So we've got a mixture of physios, sports therapists, potentially in and out of elite sports. So we've got Brentford FC physio in there as well, which is great. So yeah, welcome everybody. You never know what's going to come about from kind of just networking a little bit with people in your area, or reach out to people who are maybe on this as well. I did exactly that and randomly just kind of ended up doing a taping course abroad last week with a friend that I'd met, who I wrote kind of a chapter with in a book. So again, be proactive and see where it can get you. So I'll stop rambling. I will share this next presentation with you. Hope you enjoy it, and I'll see you in about, they're just 40 minutes-ish each presentation, so I'll jump back on in 40 minutes. Enjoy.
Hey, hi everyone, and welcome back to Grow Physio. So let's run through the anterior cruciate ligament and how we look at sort of the role that it plays in that stability around the knee, and then also discuss how we assess that clinically. It's not something that you ever want to miss, because if you do or you aren't sure, again, that can escalate into a full thickness tear and then cause that athlete to break down. So we'll talk about the anatomy and some of the culprits that are affiliated with that style of mechanism of injury. So it may not be an isolated ACL injury. You may also get that MCL, meniscal, or even sort of bony bruising reaction that can occur as well. We'll talk about the subjective markers, the little things that you want to delve into, what might give you a clue that ACL has been affected. And then we'll show you some of the real videos that I've dealt with at Newcastle Falcons, and various ones that have been contact, non-contact, etc. We'll then go into the practical side of things. So we'll head into the clinic and take you through how I've assessed some of those ACLs and what you're looking for specifically, and how that can change, be it pitch side, be it sort of in a medical room or maybe injury clinics or afterwards, and how you maybe need to kind of use a little bit additional clarity along that way. And if you aren't sure, then obviously go for an imaging perspective to give you more clinical reasoning and a surety that there isn't an ACL tear. Or if there is, then obviously that needs to be managed appropriately. We'll talk about some of the predisposing factors that can occur with that, and then we'll also draw upon some of the research and key studies that are out there. So this is your ACL, really, very, very commonly discussed. Most people will have heard of this. Most athletes are aware or will have known someone who's had an ACL style injury and maybe gone through that timely process to get back into sport again. Your ACL runs from that sort of posterolateral aspect on that femur, and it runs anteriorly, medially, and distally to attach onto that tibial plateau. You can almost separate the attachments on the tibial plateau into two portions. So there's an anteromedial bundle, if you like, and a posterolateral bundle. Again, if we think about the mechanism that can occur with this, if your knee is going into more knee flexion from that fully extended position, you can see that the ACL will become more horizontal in its alignment. And then what can happen is if you are stepping or you're maybe cutting, that kind of thing, in a non-contact environment, potentially what can happen is you add a little bit of that valgus force, compression onto the lateral aspect of that joint. As they go to push off, obviously that quad initiates and it can drag and pull that femur into an anterior position. And what can happen is then what you end up with is that sort of rotational component where that tibia rotates, and then you end up getting a tear in there. Your meniscus is also potentially involved. You can see those little crescent-shaped structures that act as almost a shock absorber in the knee. Any rotational or grinding through that during that mechanism can cause problems, and your MCL with that valgus element can also cause issues as well. Its main role, your ACL, is to prevent that anterior translation of that tibia. So again, from the perspective of deceleration techniques and then potentially pivoting as well, you have that rotational stability component that's very much required. And that's just shown here, really. So you can see there restraints to anterior tibial translation, tibial rotation, and those sort of various stresses as well. So that combination of mechanisms can occur within sport, particularly in multi-directional sports, and then obviously can add additional stress onto that ACL and potentially then cause overstress. Draw that almost medial aspect of that femur backwards, you end up with that sort of external tibial rotation, and then they almost present with a tear. Now, you can have different elements or sizes of tears within the ACL, much like any ligament in your body. I would say, unless it has just been a stretch and it's been tugged on and it is fully intact, if you have a partial tear, it is more than likely that that is going to then escalate into a full thickness tear if you carry on playing on it. And that is really important, because if you don't correctly identify them and rehabilitate them properly, then undoubtedly eventually they will get found out for that. So anyone who had a partial tear for us in our world where we were very high contact, high risk of re-injury again because of the mechanics and demands that are required in the sports of rugby union, they would always be escalated on to surgery. I'm just going to show you the sort of two differences, really. So again, you can have a partial tear where you're just damaging some of the fibers. You can see with a small amount of tear, that can quite easily escalate into a full thickness tear. We've only ever had one player who played with an ACL deficient knee, and that was someone at the very end of their career with a World Cup coming up. But we'll talk about him a little bit more on that sort of treatments, interventions, rehab, sort of follow on from this, really. Your MCL, you would just grade as you would typically, again, with that valgus force that comes in. You might have a grade 1, so it's painful on that valgus testing. No significant laxity that you'd find. Grade 2s, again, sort of more pain. Then you'll start to find that there's a bit of laxity when you compare it to the opposite side. And if it's a grade 3, don't forget that if it is sort of fully ruptured in there, you're going to end up with quite a bit of swing and play in that joint, and it may not be associated with pain. So do not be reassured if it is painless. Meniscal wise, again, you can have small tears. that maybe, particularly with more your aging populations, they will just do a little bit of a cleanup, maybe trim out some of the areas that have got sort of a small area of tear or damage to them, and then they'll wash that out. What is happening increasingly in athletes, particularly with younger athletes, probably up to around that sort of mid to late 20s sort of territory now, if that cartilage has been torn and it is repairable, surgeons are seeming at the moment that they want to try and repair that, and they're doing that because they want to try and prevent any further acceleration of degeneration or wear in that joint in future years. What I would say on that is you need to be really respectful. If they've had a repair, they can certainly come back to bite you. So if someone has had a meniscal repair at the same time that they have had their ACL injury, you need to treat that completely differently to if you've had an ACL tear in isolation. The other thing within that knee is your PCL. So opposite to your ACL, it is much stronger. It limits that posterior tibial translation. It's less frequently injured, and I would say less frequently with us. We manage the vast majority of these conservatively. We use something called a jack PCL brace, which was really useful at realigning the joint itself to make sure that that PCL was in a more optimal neutral position so it could knit back together again. And you very carefully adjust the angulations that you allow that knee joint to move in as they progress on. But you're again applying like almost a PA force directly onto the back of that tibia. Now, subjectively, what do we tend to find that the athletes are coming with? Now, sometimes it's very clear cut and they've had a significant mechanism, or there's been a history of potential maybe ACL injury. If they have had an ACL problem on one side before, the chances of them re-injuring that side or even the other side is significantly higher. The mechanism is usually one that is non-contact, but obviously it can be traumatic if some external force is applied to that knee or somewhere along the line of that athlete. It's usually on cutting, landing, stepping style movements, could be jumping and landing, and then almost trying to push off, or actually if they're going up and jumping and they're getting impacted in the air, they're not coming down straight, so they actually end up coming off on a bit of a skew-if angle. And depending on their biomechanic stability, that can obviously have an impact in terms of putting them into that vulnerable position and that ACL potentially snapping. Swelling is an interesting one. So you may see this immediately. You may get that effusion that you will typically associate with that. And we'll talk about how you grade your effusions a little bit later on. That is not always the case from my experience. What you can get with some of these athletes is the knee actually looks fairly dry, but then actually sometimes gradually it starts to swell, or you don't even get any swelling at all. And I think that is probably, again, a range to do with, is it an isolated ACL tear? Is it a partial, or is it a full thickness? Or actually, is there any associated other articular dysfunctions within there, like that meniscal problem, or is that MCL involved a little bit as well? MCLs bleed quite a lot. Meniscus stuff doesn't bleed much, but again, if you've got a bigger tear, and depending on the location of that meniscal tear, you'll get an increase in the amount of bleeding that's there. You may also get an audible sound, so they may report a crack or a popping sound within that knee joint. Now that is almost certainly going to be your ACL that has been affected, if that fits with that mechanism. Obviously, a lot of noises can come from your knees for various different reasons. I would say if there's been a significant movement where they felt instability and that's been associated with a pop, that is probably an ACL tear until otherwise proven via imaging. You may have some elements of instability or giving way, be that pseudo or true predictable giving way. Usually, if that ACL is not present or it's not functioning as it should do, what you can get is that almost predictable instability. So you put them into those positions that they don't like, and each time it just feels very vulnerable. When you're assessing that, obviously make sure that someone has things to hold on to both sides, or do it in the corner of the room so they can support themselves and they don't hit the deck. You may also have some restricted range of motion. Obviously, if it bleeds and there's a swelling that is present within there, knee flexion will go almost certainly into that end range, but that is very often to do with the swelling that is limiting it. But you also want to have a little look at the extension range, because that, if that is reduced, again, the stability in that knee is going to feel significantly less than if they can fully lock out that knee and walk on there. They're probably going to be painful on an obvious level. And also with this, what I often find from a personal perspective is some of these, they feel like something significant's happened. They feel really unstable. But then actually sometimes you reassess them the next day and they're like, oh, I think I've got away with this. But actually, don't be falsely reassured by that. What can happen is almost a hamstring can go into a bit of a protective mode. And also some of that swelling fluid around that region can act as a bit of a brace. So it can almost start to feel like that knee is a little bit more stable, but that is because everything around it is gripping on for dear life, or it's just filled and braced that region. Now, as I say, most of the time what happens in reality is that it's unopposed and non-contact. And this happens quite a lot. And this is, again, very much to do with the biomechanics of that individual and the stability they have from a lumbar pelvic level all the way down to that foot. Something is maybe made them a little bit more vulnerable. It might also be something external. And we'll talk about the external cues, like maybe the ground contact time, the surface, the boot type that they're wearing. But this is a guy who sort of did his ACL both sides. And there were anatomical reasons for that. As well as the components which we just mentioned there. I would say that these are the ones that really are not unforgivable, but these are certainly ones that you as an individual, if you're going through a thorough screening process, you should be able to try and reduce some of these style injuries. By comparison, there's sort of a big external force that comes in here. So this guy, again, you can sort of see the demands onto the knee, right and left side. That are on here. Both of them went prior to any sort of contact impact with anyone, and one of them was actually just on stepping backwards, so totally unopposed, stepped back into a sort of forward propulsion and felt that knee suddenly go. You can also have this sort of scenario where they're reacting to something external, so again, backpedaling, similar mechanism, and you can see here, you can even watch this in the case study presentation. This is an athlete that we had who did his ACL in this movement here, and we'll show you it in a slightly different angle. You can see here, so as he steps back, it's his left knee that goes, and you can see as he lands, he just goes into that typical injury mechanism. From there, basically that knee, just that ACL blows in that position. Very clear cut, bit of a no-brainer when we assess it that is not going to be carried on. When you assess it, again, it is moving a little bit too much. Maybe some little clues and things with that coming back from other injuries. We taped it. So was there some sort of switch off around that region? You can see me carrying him off with the head physio there. Other ways that you may injure yourself, or if there's some unpredictable elements, again, this guy goes up, comes down, and you can see there's a little melee breaking out on the ground, and basically he just lands directly into it here. So he doesn't realise that there's someone there. The knee gets forced into that valgus deformity plus rotation. So again, that as a typical mechanism of injury for an ACL was pretty clear cut. He actually ended up with a high-grade MCL only with some meniscal irritation. And again, this is the other way that you could have it. You can see the scrum half here. Again, about to clear the ball. Someone comes flying over the top of the ruck that's here. Comes in, impacts. You can see him down on the ground there. Watch it again. Knee slightly flexed, more flexed than you would typically find with an ACL. He was actually, again, a proximal tibiofibular joint injury. But again, the mechanism that is occurring there, had he been in a little bit more knee extension, I would suspect that he is probably going to go and do his ACL. Been very, very fortunate to get away with that one in some respects and had him back within about a month instead of 9 months. Other things you can have, it can also occur, obviously, in defending. You can see here the guy who makes the tackle and ends up lying next to the hoardings there. As he goes in, he just gets his knee caught, and the impact of the player, again, the weight of that individual landing on him causes that problem there. So you can see the tackle comes in, and he just lands and impacts directly onto the opposite player, and then that knee, again, from an ACL perspective, blows out. This is an amazing video that has become available. I've just slowed it down for you here. So someone doing a reverse Nordic, and you can see that ACL suddenly just stops supporting that knee. He thinks giving it a quick little rub will make things all right again. But if you watch that again, just impact-wise in slow motion, as he comes up, that ACL ruptures. And you can see that rapid translation of that tibia coming anteriorly. So that ACL is no longer supporting that knee. And what I do want to highlight really is when you go about testing this, because this is a really important point. I think early on, either pitch side or maybe immediately after you brought them into the medical facility to assess that knee, is the prime time to work out whether or not there is some laxity or play within that joint. What typically happens, as I mentioned before, is as swelling kicks in, protective hamstring kicks in, you may not be able to get that same range of motion. So when someone has gone down with an injury of this mechanism, the initial testing is vitally important with this before all those protective systems kick in. So immediately, really, really important to get your testing right. That is really difficult in a pitch side scenario. You do need to compare it to the opposite side as well. But again, as you go through that process to the injury clinic the next day, it may look completely different, and don't be falsely reassured by some of them. You will need to monitor, again, if you think that someone has had an injury and you don't think that that ACL is affected, do keep checking in on them throughout that game. What are they feeling? Any elements of instability, anything that's worsening, any swelling that's occurring, what is happening with that? And again, from that perspective, your hamstring, again, is worth looking at in quite a lot of detail from a range perspective. Has that hamstring suddenly locked up and gripping on for dear life around that posterior knee? And is that limiting their straight leg raise, their slumps, etc.? And is that a neural thing, or is it true hamstring restriction that's occurring there? Now, I just want to show you the effusion. So if you do have fluid on the knee, again, you need to be able to grade that and monitor how much fluid there is. So this video will hopefully give you a little bit of an indicator of the different gradings and what you'd look for.
You don't see anything of it, and it doesn't really come back down again. That, again, you could probably put that down as a trace. If you sweep up this side and then sweep down the lateral side, and then you start to see a small pocket of fluid as it was before, you would normally say that that's a grade 1. A grade 2 would typically be a sweep up the medial aspect, and then it starts to fall back into that area. It doesn't fully fall back, but then once you start to sweep down the lateral aspect of the knee, it then starts to protrude into that area again fully, and you'd normally say that's like a grade 2. And if you can't change the swelling, so you can't shift any of that swelling from that medial capsule, and it just falls straight in, then that's generally when you'll find that that's that sort of higher grade 3 sort of effusion that there is in the knee, and that's normally associated with some pretty significant pathology that's happening.
So I'm just going to take you through the 3 different main tests that you see for your ACL, but I've just highlighted them here so you can look at the different angles and pre-positionings that they're going to be. So your anterior draw at that sort of 90-degree region, again, thinking about your PCL injury, and we'll talk about that in a sec. Your Lachman's being more towards that 25-30 degree mark, which is probably more accurate, but a little bit more challenging with your bigger athletes. So I'll show you an alternative way to do that. And then again, your pivot shift, which again, surgeons are absolutely amazing at doing. And what you get is that sort of typical clunk. But if you watch this video, hopefully it sort of familiarizes you with some of the considerations during that testing.
Okay, so from an ACL testing perspective, what we need to make sure is that is there any anterior translation within that knee joint itself? So there are 2 different reasons why you can have some increased translation usually within that knee joint. The first is that you've got a true ACL tear and that there's some laxity that's present. The other reason is you might actually have a PCL tear, and that causes the tibia to sit in a posteriorly translated position. So what you just need to be careful of is as you anteriorly translate during your anterior draws or your Lachmans, that you address the initial position that that knee's in. So it might be sitting back and then present like you've actually got a lot of laxity in the joint, but it might not be your ACL, it might be your PCL that's torn, that's not holding your knee joint in a neutral position. So to assess those bits, if you just bend up your knees into, so your feet are flat, a really nice way to do that is almost look at the angulation that the tibia is sitting in one side compared to the other. And you might want to use something like a business card and just angle it down here and look at the angle that your tibia is sitting in. Because if one is sitting slightly further back or at a slightly different angle, even if the heels are at the same level there, this tibia might be just dropping back posteriorly and give you a false reading when you do your ACL. And that will obviously implicate how you rehab the athlete on the back of that. So if you just bend this knee down for me, typical things that you would normally find with an ACL is that you would usually have a pretty significant trauma. It may be contact, it may be non-contact, but you might have an effusion within that knee joint and within the capsule. So the ACL sits within there and it will cause that fluid accumulation, and that's usually a bit of a clue that there's something going on, either cartilage or cruciate, within the knee joint itself. So there's different tests that you can do. Probably the most simple test that you can do is the anterior draw test, and what you're trying to do is move the tibia anteriorly from this position with your knee at sort of 90 degrees in a relaxed position. So you want to make sure that the hamstrings are pretty relaxed when you do this. So just make sure that there's no tone, have a palpate through, make sure that they're not holding on. Position your thumbs into the eyes of the knee. And what you're going to try and do is, or I find it's easier to try and just create a slight lift in that joint. And then what you're doing is you're just pulling to see how much joint play there is in that joint there. So you can see the tibia starts to move forward as I apply that force. Now there's a definite end point, thankfully, in this situation. If there is a mushy end feel or it doesn't spring back again, chances are there could be some sort of tear within that ACL. So you're looking at the distance, but you're also looking really at whether or not there's an end feel, and whether as you pull out, that starts to spring back to its sort of resting position, if you like. And that's that's the tension within that ACL holding that position. The other way that you can do it is something called the Lachman's test, which again is really useful, probably a little bit more specific and a bit more sensitive than the anterior draw. And you can do that in this position. So the Lachman's test, you're testing it, instead of testing it at 90 degrees, you're looking at more like a 30 degree, 40 degree angle of knee flexion. You're going to fix the femur, possibly put it in a slight little bit of lateral rotation, and then you're going to hold the tibia if you can, and this is easier with a smaller athlete. I'll show you an alternative way to do this if you have a bigger athlete. So this position, you're fixing with your proximal hand, you're coming in behind, and what you're doing again is applying that anterior translated draw force, and you're monitoring to see how much glide there is within that joint. And again, you'll compare that to the other one, have a feel for what it feels like as an end feel. So is it a springy end feel, is it a bit empty? And these are much better to test acutely, because that hamstring reactivity will certainly kick in and stop that movement. There's a bit of evidence to suggest the first 24 hours is the best time, and then on the back of that you're probably looking at about 2 weeks to get a good representation really as to the accuracy of that joint. So the other way that you can test the Lachman's is to do it in this position. So you're going to bend your knee over the end of the bed, and you're going to hold that position in between your legs. You're going to do exactly the same movement, so you're going to fix the femur and then apply a draw force anteriorly. And again, you're just monitoring really what the amount of joint play there is and what that end feel feels like. The other test, and the last test really of the three that we generally use, is the pivot shift, which they usually use within an orthopaedic setting a lot when the patient's under general anaesthetic. But you can certainly do the same thing with this test as well. So the way that you would do this is you're almost looking at whether or not there is a relocation of the tibia as you're going from a flex position to an extended position. And what happens is as that tibia drops, does the ITB and the tension within that ITB pull that tibia back into its neutral position? So you want to apply a valgus force to the knee, and then as you come up through here, you're taking it to around sort of 60 degrees, and then apply the valgus force, slight lateral rotation to the tibia. And what you'll often find is as you go from a flex position to an extended position, around that 30-40 degree mark, you will often find that it clunks back into position again. And that is the tibia just starting to pull back into that neutral alignment again. So they're the three tests that I would normally do for the ACL. They will give you an indicator regarding whether or not there was a definite clunk on your pivot shift. The Lachman's, again, looks at it more at 30 degrees, and then you've got your anterior draw that's quite simple to test, but just bear in mind that the PCL, if that's injured, it will start in a posteriorly translated position, so that false positive may occur.
So there you go. So just to show you, once we remove everything else, you can see there that Lachman sort of position. We're just trying to draw that tibia forward, and that is your anterior draw at more 90 degrees. So again, that is the movement that you're trying to create. So you need to stabilize proximally and then move distally. Try and use your body weight or use your arms rather than your hands, so you've got a little bit more feel that's there. And just on the right hand side, just to show you what a normal pivot shift clunk looks like, you can see that relocation of that tibia just drop in an AP direction as that IT band attachment onto that Gerdy's tubercle on the sort of anterolateral edge of that tibia just sort of relocates the tibia back into position again. And this is just to show you the different phases in a little bit more detail. You can see that valgus force, number one. Going to add that little bit of rotation, number two. Take it up into flexion, and then add a little bit more force. And again, that iliotibial band, reducing the flexion from there. Just to build on what we were talking about before from the PCL side of things, again, if that knee is PCL deficient, what you will often find if you put it at 90 degrees or even sort of onto the bed in a crook lying position is you get that sort of lag sag sign that occurs there. So that tibia just drops back very subtly, maybe sort of half a centimetre, depending on the size of the athlete and tear size. But it will just look like it's got slightly sunken back there. And I've just indicated that with the arrows there. But you can see if that is the starting position rather than starting from a neutral perspective, as you apply that sort of PA force, as you would do with an anterior draw, Lachman's or otherwise, then what you're going to get is an increase in the amount of movement because it's actually starting further back again. So that is an important one to differentiate between your ACL and your PCL injuries. Now, there's clearly different variables that influence the ACL, and some of those are modifiable and some are completely non-modifiable. So by the modifiable ones, that's when we're looking at the neuromuscular control and trying to develop that optimal movement environment that we try to create there. The non-modifiables that you have absolutely no control over is your sort of almost anatomy that individual you have that you're working with is, their gender, their age, their hormonal levels at different stages during sort of the month with females. And again, sort of past injury histories and things, we don't have any control over that, or even their underlying level of laxity, hypermobility that may be occurring within there. One of the key modifiable, non-modifiable things is obviously that sort of gender, really. So women are at a much higher risk of ACL injury. We're looking at 1.5 to 6 times more vulnerable than men, according to Hewitt in 2007. And the reason for that is generally a combination of the anatomy that occurs with that. So again, that Q angle, which I'll show you on the next slide, is that angle from that hip region into your sort of middle of knee. So the more angled they are, bearing in mind women generally have wider hips for childbearing purposes, and that's their anatomy, you're going to have an increase in the amount of valgus force, which predisposes them already to a little bit of medial rotation and a little bit of valgus at the knee, which again, thinking about the injury mechanism, is almost preloading them in that position. Now, what can you do about that? Well, again, you could cue and try and teach and coach them to become better lumbar-pelvic control-wise through there, get more stability around that hip and trunk region, and also trying to move away from maybe quad dominance, which has been found more in females, so thinking about that quad-hamstring ratio. Generally, males have a higher level of hamstring strength than females, and women are more quad dominant. So when that quad fires, thinking about how that implicates and influences the femur as they drive off when stepping can also be a factor. There's also a suggested hormonal effect. So thinking about sort of menstrual cycles, over the course of a month, that hormonal level, if you are working with female athletes, will change. So potentially in that pre-ovulation phase, that risk massively increases to about 2.4 times higher than it does post-ovulation. So again, from a coaching perspective, do we need to educate the coaches or the athletes and people like that in terms of what we put in those sessions, and maybe vary that if you are going through a rehabilitation program, because if they are more lax, then clearly they are going to be more vulnerable to injury. So maybe you take out some of the more high risk activities pre-ovulation and do those post-ovulation. The other things which are worth considering with females is contraception. So if they are taking oral contraceptives, that may actually offer a 20% reduction in risk, and particularly with those younger individuals, 15 to 19-year-old. And again, just to highlight, in the middle, you've got your Q angle that I've just indicated there. So again, from that sort of ASIS to the middle of your patella, and then down the line of that tibial shaft is going to create your angle. The more internally rotated, twisted, lack of stability that they have around that trunk pelvis single leg balance, and also remember, look at that dynamically, is also going to be really important. So you're going to look double leg squat, split squat, single leg squat, what they're like landing, what they're like sort of lateral landing in particular, and look at the multi-directional control that they have. So if they do go into a landing mechanism, or there are variables and things that potentially expose them to increased risk, then you have already prepared them and identified that prior. Other things that may have a factor, again, a sort of a higher center of gravity. So either a taller individual with longer limb length might have a factor, but also those who don't kind of almost use their quads and get that low center of gravity that you'd normally find gives you a little bit more stability. So those individuals who are more upright generally have a lower knee flexion angle, and they will have an increase in their knee abduction moment during that 30-degree cut. From a ground perspective, you need to also think about what they're training on. So wooden floors, generally you are going to have an increase in the amount of stickability between the shoe and less give than you would do on grass. Dry grounds may also be a factor in terms of sort of increased injury risk. You may want to flip that the other way, again, thinking about whether or not something like a really muddy pitch that they can't grip onto. Generally, that will allow a little bit more give. So if they are landing and standing on a dry ground, again, there's less give in the ground itself. So again, is that going to shift up to the knee? And then when they go to rotate, is all of that torsional force going through the knee itself? You sometimes find that more typically with an artificial turf, particularly with some of these more modern grounds, I find, rather than that old school cement with felt on covered in sand, really, which has a little bit more slidability. The ones which you can almost apply a stud into and then try and rotate, particularly with blades that we'll talk about, the increase in risk is about 1.4 to 1.6 times more likely. And again, thinking about that shoe surface interface that we'll go on to now. So again, what the athlete is wearing on their feet can have a bearing, and what they are playing on can have a bearing. So whether they are training on one surface or maybe playing on grass on another occasion, or if they are doing a lot of work indoor, potentially on like a typical on the right hand side there, like an old school gym floor. And again, the stick that they will have, whether they are doing cutting activities, rotational drills, etc., may actually be predisposing them to injury. So they might be things that you need to look at from an education perspective with coaches as well. The studs are really important. So on the left-hand side here, you can see these are almost like blades. So if you have a blade that inserts into the ground and someone tries to twist and rotate off it as if they are pivoting or stepping, you can see that sometimes the blades get stuck into the ground and they don't allow that rotational force to happen at the foot. So clearly that will send all of that higher up the chain. I would say if you have someone who is vulnerable, Maybe you need to do a bit of education in terms of the type of stud they use. These are just a pair of World Cups or Copas that I played in sort of days gone by, no ACL problems. Amazing stability probably as well to combine with that. But again, a stud will allow more rotation than a blade will. So again, injury-wise, is that a factor? As I mentioned, depending on the environment that you're playing in, has an impact on that ground contact surface time. So on a really muddy pitch, again, there's probably a little bit more give and slide versus maybe on a really dry, sunny day in the south of France. We went to Toulon and won. Very different conditions to the Newport Dragons where we went, where it was an absolute mud bath. So the surface, and as well thinking about, it's not just grass, but thinking about the conditions that they're playing in can also have bearing. Other non-modifiable factors that you need to think about that predispose that individual is that narrow notch width that's being discussed by Everhart and Evans, the presence of a ridge, your PTTS angle that is higher than 26.7 degrees. That is the angle really between your femur and your patella. So again, thinking about the angulations that are occurring there, again, nothing we can do about it, but maybe a factor. Is there some ACL impingement? And this one really, so again, from a volume perspective, over the course of the season, if that volume increases, particularly in female soccer players, that was an indicator of an increase in risk that occurred there. Now, it's important to wonder whether or not we need to go for surgery with this. So I would say with all of our individuals, as I mentioned before, if there is a partial tear or a full thickness tear, all of those individuals, bar one, over my entire rugby career, went for surgery. But in terms of the literature, Grindon et al. Looked at 300 highly active patients. Within the non-operative group, they had surgery within 2 years. It was 37%. So of those who opted not to have surgery, they then went on to have surgery. And they had good outcomes in about 52%, or 11% had poor outcomes. In your ACL patients as well, when they were reviewed at 5 years post-injury with your ACL deficient knees, again, 82% of them had returned to sport within 3 months. Of those, they had had a secondary injury within the 6 months following that initial injury. So again, it probably indicates that their injury risk is much higher, not just on the ACL, but also thinking about other structures within that knee, particularly the cartilage. And when we looked at it at 5 years, again, only sort of 35% were still playing. When we look at, again, meniscal pathology associated with an ACL tear, it's pretty high. So again, if they are ACL deficient, their risk of meniscal pathology at 1 year was 40%. At 5 years, 60% had meniscal pathology. And at 10 years, they had 80% of them had meniscal pathology. That is huge. So of those who you do not operate on, they are almost guaranteed to have meniscal irritation at 10 years. These are the different types of tears that you can have within that meniscus. And again, depending on the severity of them, they will decide whether or not we just trim it, whether or not or you go about repairing that. So that is a consideration for the surgeon. And again, in a younger athlete, if it is repairable, I think they're opting now more so to repair them for the longevity of that cartilage. The other question that often comes about is, does the speed of surgery matter? So again, another relatively decent sized study looking at 183 patients. Of those individuals who had surgery in the 12 months following injury, what you found was their meniscal tear rates were 41.7 versus if they had the surgery 12 months after injury. So again, the increase in meniscal tears is much higher in those if you delay surgery. So again, for those individuals who maybe go, you know, I wouldn't mind trying conservative management of this, the implications on the meniscus are pretty severe because you may almost have a different looking knee at 12 months or beyond than what you would have had just getting the surgery done within that 12-month period. That's exactly the same for the chondral damage. So in the first 12 months following injury, you're looking at 10.7% that had chondral damage versus 31% who had that done after 12 months. So I think probably the summary of that really is ACL reconstruction should be carried out before 12 months to reduce the risk of associated meniscal tears and degenerative changes. And then again, if we look at a much, much bigger study looking at the meniscal lesions in adults, that increased by 1% for every month that elapsed from that injury to the surgery date. So obviously the more time that you leave, the increase is higher for meniscal injury really. And that's really important as well when we think about the type of injury that we have. Do we have an isolated ACL injury, or is there anything potentially associated with that, be it the MCL or that medial meniscus? And what you can get is what's called this sort of terrible triad or unhappy triad really, where you end up doing all of those together. And then the other question really is on the back of that, once you've diagnosed it, what do we sort of tell the individual? I would certainly be inclined to suggest if you think that there is potential for an ACL tear, we need to go through the process to make sure that we confirm that. And that will obviously be an imaging side of things, get an MRI done, work out the extent of the damage that's there, and then we can almost talk about the return levels. Do not reassure them that it is okay unless it is absolutely okay. And in terms of returning them, they'll often ask, well, what does it mean if it is injured? There's lots of different protocols that are out there. I think we're moving certainly away from a 6-month return, more to a 9-month. But if someone has complications or they're not in a sort of full-time environment with rehab, or they're not compliant, or they've had ACL vulnerability, 12 to 18 months isn't unheard of for those, to try and make sure that we get all of those mechanics correct again. And what you're going to do, which we'll run through in the subsequent sessions, is look at the treatments, the interventions, and that sort of rehab protocol that you're going to get. General summary is 6 months is unsatisfactory in terms of the risk and recurrent injury rates that occur with that. And sometimes what can happen is even after surgery, they end up with failure of the graft, and there can be various different reasons for that. Both the intrinsic things, which we can't do a great deal about, and then the extrinsic things, which again might be due to the poor graft quality, incorrect graft placement, poor fixation, associated injuries to do with the meniscus or the chondral region. And then also it's on you really to make sure that your rehab plan and advice is up to speed really. So again, from a non-operative level, looking at older individuals, these guys might get away with it. You might have someone who's got laxity on your ACL testing, your Lachman's 97% here. You can see positive pivot shifts. What does that mean for an older individual who maybe doesn't want to go back to high-level sport? Well, 7 years on, most of them were fairly satisfied, 83% pretty satisfied. And again, thinking about what is happening within that joint, are some of the degenerative changes, are they occurring gradually in the background? And also, is that actually giving them a little bit of stability? So just to summarize really, in terms of the ACL assessment side of things, getting your diagnosis is absolutely vital, because your ACL has a massive role in terms of stability and dynamic control around that knee. We need to think about the timing of when we assess it, and the importance of that initial 24 hours being probably the most accurate in terms of my experience, or you may have to wait until all of that sort of swelling, effusion and things has gone down. But if you aren't sure, again, get your relevant testing done, MRI scans, etc. The false reassurance patients, those individuals who come in and they've maybe sort of felt some significant related injury that could be associated with an ACL injury, but then suddenly gets better, don't be fully convinced that that has settled down and that person is ready to go back into training again. That might be a false positive that you're getting. If it rapidly improves, it might be to do with the hamstring or some swelling, bracing that's going on there, that's giving them that sort of almost false reassurance of stability. We do need to think about the predisposing factors that occur, and particularly with the non-contact ones, they should, in theory, be the ones that you can prevent happening, because you can try very much to make sure that their biomechanics and things are as good as they possibly can. It doesn't mean that it's completely fail-proof, because they are more vulnerable anyway. But again, those are the ones that you need to get a hold of early doors, put in some measures to make sure that you've got the injury prevention side of things correct. You can only control the controllables, things outside of your control. If someone is incredibly lax, female, at that sort of menstrual time, again, they are going to be at an increased risk of injury. And don't forget, normally with an ACL style injury, there is some sort of other pathology or irritation to either the joint surfaces, be it bony bruising, avulsions, MCL tears, meniscal injuries, etc. But that's it, guys. That is your ACL assessment done. Do have a good feel of these and make sure you compare it. Ideally, find someone who is ACL deficient and have a little feel with their knee, and you'll feel that laxity that occurs there.
Okay, folks, so there we are. There is the first half of tonight's action complete. Hopefully, a nice little insight into some of the sort of theory, how it happens, and then sort of how it might well present and how you test it, really. And I think the interesting bits are sort of, that sort of comparison potentially between someone who's had an ACL tear and they decide they want to try and manage it. We have had some in the judo worlds as well, where we've kind of had really, really good athletes who move really, really well, being an ideal candidate to try and manage this. But as time goes on, they just have kind of more and more instability episodes, which potentially then leads to more irritation to that meniscus. And then that meniscus just gets a bit chewed up really from there. I'm just having a little look through. So if anyone's got any questions at all, then yeah, fire away. So first question, how effective is Lely's test for ACL? So I think this is a great new one, which to be fair, I haven't used a massive amount, but it seems to be a bit of a go-to when you sort of see it done on YouTube's or social medias and things. It really looks like it gives a really significant indicator as to whether or not there's a tear there. Now, for me, when you look at it, I mean, it's going to be a full thickness tear and it might not pick up some of those sort of partial tears and it might not pick up some of the associated collateral damage that occurs with it, like your meniscals or your collaterals and things. But I haven't used it a huge amount, Trevor. So yeah, not 100% sure in terms of its sensitivity, specificity. When the ACLs were coming through thick and fast, usually my go-to was the Lachman's, and then potentially get the doc to do a nice little pivot shift because she was a bit of a guru as a knee surgeon orthopod from there. Oscar, when thinking about ACL tears, how often does something like the unhappy triad flag up? I wouldn't say that it happens all the time. So I know it kind of becomes something that is really closely linked with ACL tears. Quite often in our worlds, we actually just had an isolated ACL tear. So the rest of the knee was pretty stable. When they then go and MRI it, most of these rugby guys have got pretty chewed up meniscal injuries and little things that have kind of been there anyway. So sometimes it's a bit tricky to 100% confirm that all of this has happened at the same time. Usually, if there's any sort of acute bony impact that's happened, then you'll usually find that lights up on an MRI. So you can sort of make a pretty good guess if there's been some sort of acute trauma and some meniscal injury that's associated, then yeah, it's probably going to be a fairly high level impact. But yeah, they're often kind of those non-contact ones that come from there. Callum, how commonly would we see ACL injuries from a hyperextension mechanism? I'm not 100% in the literature. What we found was generally it tended to be cutting. Some of the ones that we had that were hyperextension, you saw an image of it there where someone had probably, hand on heart, probably had like a little partial ACL tear, step backwards in, and then that knee kind of gave into hyperextension. The other guy who you saw on there when he stepped back, he actually went into some hyperextension there as well. But I would say most of the time you see it on that plant of the foot, they go to pivot and that knee just kind of shears and that ACL tears. I'll find out those answers though for you. So I'll make a little note. So we've got Lely's test in terms of it. I'll try and find out the sensitivity and specificity in the second half. I'll find out about the hyperextension versus cutting mechanisms as well for you. Has anyone else got any questions that you want to ask? Or do you want to dive into the treatment aspects after? I'll give you another 30 seconds. But Nothing coming through. All right, folks. Well, what we'll do, we'll blast into the treatment and management sort of parts of it. As I say, this is it's not rehab based, so this is more those joint mobilizations, taping techniques, things that you might find and release, things like that. The rehab bits will all go through next week, but yeah, by the time you sat for an hour and three quarters going through these webinars, usually that's enough and people are pretty fried. So yeah, if you are interested, tune in next week and we'll go from there. Okie dokie, right, enjoy. Again,
Hey, hi everyone, and welcome back. Athlete maybe rolls out from that afterwards and things we need to consider, including some of those associated pathologies, and then also some of those early activation techniques, interventions, thinking about co-contractions of quads, hamstrings, and things, and how that is really important early doors, along with the role of that soleus and those glutes. We'll talk a lot about the sort of manual therapy techniques that you may need to, again, restore some of that range of motion, particularly with an emphasis towards that extension at the knee, some of the scar management techniques that you might need to address as well, and then also some of the sort of neurodynamics and other adjuncts that you may require along that journey. You may require some additional support from other health professionals, and we'll talk about those through the journey. Now, first of all, we need to just know a little bit about the surgery, really, and the different graft types that there are. So there's three typical ones. You've got your patella tendon graft, you've got your quad tendon, which is not seen very often anymore. And then at the moment, most of them are basically using that semitendinosus plus or minus that gracilis graft that you can see on the right-hand side. So if you are picking this athlete up, maybe later on down the line, you can quite quickly tell what kind of surgery or graft they've had based on the scar position that they have there. Patella tendons clearly, along with quad tendons, generally have a little bit more complications, if you want to call them that, in terms of anterior knee problems, patellofemoral issues because of the scarring. They've cut through things and generally sort of taken a small graft out of that appropriate tendon. Now, the other thing to think about with ACLs is also it's not always just the ACL that is affected. You might have joint surfaces that are affected. You might have meniscal injury, MCL injury, or additional sort of osteochondral things, and that may have undergone additional repair. And we do, in particular, need to respect the meniscal repair individuals with that. This just shows you the position again of those different types of grafts that you can use. Again, that quadriceps tendon, the patella tendon, or that semitendinosus gracilis graft that is the more commonly used one at the moment. Now, you can have variations in terms of the size of tear. For me, anyone who has a partial tear, who wants to go back to anything competitive, anything stepping, cutting, anything they're going to have opponents who maybe tackle them, we need to really be looking at getting that operated on. There have been a few scenarios, we talk a bit more about this in the assessment part, that have then managed to sort of almost manage conservatively if it has been stretched. But I think any partials, any full thickness tears typically need certainly all of them need a consultant opinion, MRI scanning, and then make a collaborative decision in terms of what's going on and the implications and the risks associated. When you're assessing them, if you don't have access to that early doors, then again, you're going to do your manual assessment objectively, looking at laxity levels, the degrees, the millimeters of play within the ACL and those anterior draws, Lachmans, etc. And then also the same sort of thing really on your MCL and your meniscal testing. And then again, that may go on to have a meniscectomy, it may have a clean out, a clean up, or actual repairs, which obviously take a lot longer. Now, just to show you diagrammatically what happens, so generally the surgeon goes in and cleans up the area where that ACL was. They clean out any meniscal stuff, and then they often make an insertion into the lateral femur. That may come from internal position initially through a guide hole, and then they do exactly the same onto the medial aspect of that tibia. And then what they do, they then have two access areas to go through. They'll then take the hamstring graft from that semitendinosus, gracilis territory, and they'll just feed that through. And then they almost use these little plugs just to hold everything in place. Now, what does that look like in terms of sort of the reality when we get that done? But again, this is sort of just showing that regeneration of that ACL, and this is sometimes why it takes a little bit longer. So they obviously had it at around some initial concepts of accelerated protocols being 4 months of being shot out the window. 6 months was accepted if they weren't going back to any cutting multi-directional activity, potential just runners. But if there's any sort of increased rotational demand in different planes, again, we need to be thinking about really that 9 months to 12 months period to reduce the risk of re-injury. What does that look like in terms of sort of internally? Well, this is a nice little clip really of that taking place, where they're sort of removing the ligament to create space for the new graft to go in there. They're making a pilot hole internally, and again, they're drilling that through with the appropriate size drill. That then creates an avenue really for that new graft to be fed through. And you can see as they try and grab it and pull it through, they've got their stitches that are retrieved, and then that new graft being moved straight into the newly drilled socket. That will then sit there, and again, over the course of time, that will regenerate, embed itself, and then hopefully create a sufficient amount of anterior tibial restriction, as well as some of that rotational component. I think the vital thing with this is to try and make sure that everything around that graft is basically doing more and more of the work, so there's as little pressure onto that ACL graft as possible. The other things just to think about, again, is it an isolated ACL or is it a meniscal repair option? If it's an MCL that has fully ruptured at the same time, the likelihood is that will be reconned during the operation. Similarly, with sort of posterolateral corner, bucket handle tears, anything significant, they are likely to be sutured with those suture patterns that you can sort of see there. The other thing that is worth considering, and often happens, is you get this osteochondral defect or bony bruising that can occur because there's been significant trauma and impact into either the articular cartilage or that bony surface. So there may even be potential sort of microfracture treatment that goes alongside this. And I've just showed you this on the left-hand side there, so you can see the different areas from the severe soft tissue swelling that you can see, all the way through to the torn MCL, the torn meniscus. You may also, importantly, get a sprained PCL, which often just settles down on its own because you're in a brace anyway. But again, if there is any significant tear of that PCL, that may need to be addressed during the surgery. Obviously, the significant important factor in this talk is the ACL, so that you can see highlighted there that torn ACL, and then that associated bony bruising that's going on there. You may have heard the term terrible triad being thrown around, so that's when you do your MCL, your meniscal, and your ACL tear, plus or minus that PCL as well. On the right-hand side, I've just put this on for reference, so you can see that there is a tear in that meniscus, and again, they often, in a very similar sort of fashion, they put in sutures to hold those two areas that have come apart together, so it knits together, so you've got a suitable connection there. Now, there's quite a lot of attention around the lateral tenodesis at the moment and how much that can have an impact on that multi-plane stability that's going on there around that sort of ITB region. Now, the subjective history will be pretty important in terms of whether or not the surgeon goes for this or not. What I find, and from talking to surgeons in this world, if this has been a non-contact, unopposed injury, which is the vast majority of those ACLs at about 60 to 80%, they may consider something called a lateral tenodesis. Now, there's obviously a lot of different factors to do with the individual and the sport as well. So then again, they all have to take that into consideration. But if you have a situation a little bit like this, and you'll meet this gent in the case study ACL presentation that we have there, you can see there no contact has happened to that individual. It can also happen during stepping itself, or actually with some individuals just stepping back into an extension position and then pushing off. Very much that plant, then that sort of almost torsional ACL gives, and then they almost have all the issues that come on the back of that. Now, what is the lateral tenodesis and why is it so important? Well, I think you can probably see from the diagram here, and I'll show you this in a video on the next clip really, but if you look at the role of that strip of additional IT band that is on the outside there, what that's doing is providing some lateral stability, because what they've found is almost on the lateral aspect, what you might find is it is associated with subluxation of the lateral compartment of the knee, and therefore an injury to the lateral soft tissue envelope. If the lateral structures do not heal, additional lateral surgery may be needed to assist with rotational control. Now, this is from the knee surgeon that we used, an amazing guy called Andy Williams, one of the leading sports knee consultants who deals with athletes all the time, and he has started to use this on a regular basis. This just shows where it is. So it's from that lateral epicondyle to that Gerdy's tubercle. The graft goes in, and you can see it's all supportive on the lateral aspect there. So not only are you trying to prevent that anterior tibial translation, you're also getting that rotational stability to reduce that. Now, quite interestingly, he's done a study in relation to this, and what he found that he had a recurrence rate of around 4 to 6%. Now, bearing in mind that a lot of different people have genetic predispositions to this, so it might be age, genders, alignments, it might be the sports or the positions that they are playing in. 4 to 6% is a pretty good level for reoccurrence, for bearing in mind that these are high level athletes going into elite sport a lot of the time. But with the tenodesis in place, that 4 to 6% has reduced to 2%, so it seems to have a massive bearing on the reduction of re-injury again with ACL, so seems to have a role. Now, I've just included this gentleman here. So this is one of the Tuolangis, the original Tuolangi. He is the only person who we have ever had who did not have ACL surgery after an ACL tear. And the reason was quite unique, to be honest. And you can see him here pre-ACL tear, doing what he does best, full-length tries. Absolute powerhouse of a man and an incredible guy to rehabilitate. But again, what you can sort of take from this was a unique situation. So this guy had the World Cup, his last sort of swan song, if you like, of his rugby career. He injured his ACL about 4 months prior to this World Cup. So he was in his mid-30s, coming to the end of his career. Because of that, if he had had surgery, there is no way we could have got him back to the level that he required. He also had quite a lot of osteoarthritic change within that knee. So again, all of these factors, and along with some absolutely gigantic quads and hamstrings, we actually managed to get him back into that World Cup squad for Samoa. And we did a lot of work on that deceleration work, so very much marrying up that soleus, the medial hamstring, and that glute really. You can see him, this is him actually at the World Cup, flattening a Japanese man with that exact ACL deficient knee.
Yeah, it was a loose kick from Ono initially.
So again, huge demands, multi-directional bits, all in that same play. He has to adjust footwork-wise, plenty of bodies landing on top of that. So that knee is a pretty vulnerable knee, but actually because of the work that we've done, we managed to get him back there. What would happen sort of post-injury, if you like? So again, obviously this isn't an acute injury when they come back post-surgery, but they will be non-weight bearing. They are likely to be in a brace, and you are going to have a very big swollen knee. So what do we need to do really? Well, there is very little point in trying to take them off their crutches and getting them to walk abnormally until they are ready. So certainly reducing the amount of body weight that's going through that knee is really, really important. And again, using the upper limbs is the obvious way to do that with crutches. Now, you are going to want to address the swelling that's there. To assist that, you may use some of these cryotherapy bits of kit like your Game Readies, your Physio Labs, or even just chucking on bags of frozen peas for 15-20 minutes with a layer of protection. The compression element is really important. You basically need to try and reduce the amount of swelling, otherwise you are not going to achieve enough extension or flexion, because that joint capsule will be absolutely full, as well as extra-articularly. The other things to think about are education-based parts of that, and some of that will be to do with scheduling some of the time off for that individual. If you are looking at a 9-month program of returning that individual back to their sport, again, Sometimes there are going to be periods where you need to desperately ramp things up. However, there will be also times when it's a little bit less, there's less requirement really for that intensive physiotherapy rehab. So again, come up with a decision with your individual in terms of when you're going to give them a little bit of time away. It is a demanding journey. You do have psychosocial bits and pieces that go on with that as well. It does become frustrating being in a gym all the time away from the team. But again, factoring some of these moments for them to look forward to along that journey is really important. Now, the other thing to think about when they have had their surgery is the wound management side of things. Now, I cannot stress this enough. If you end up with an athlete with an infection in that knee, it is a disaster. It has to go back in for surgery. There may be other complications that come with that, and it generally tends to prolong things significantly. So you do have to make sure that you maintain a completely sterile environment. Do not encourage them to take off their own dressings and reapply them unless they are starting to weep, or you have someone to do that for you. Typically a wound management nurse or a doctor are the people who do it. However, we have been known to do it. Just make sure you're gloved up, you've got a sterile environment, you are using your iodines, betadine, skin cleaners appropriately. If you are required to take out the sutures, again, use a sterile suture cutter. Make sure you're not upsetting any of that scabbing that's going on there. Again, specific dressings for this individual. The other thing is the brace. So you will undoubtedly have an individual who is using a brace post-surgery. This helps again to control the flexion and extension ranges that they have, but also that rotational or valgus varus stress that may well upset that knee and the other structures that have been repaired. Now, in terms of the angulations of that, and where you're going, that is going to be very surgeon-led. So they are likely to give you, and certainly should give you, a specific, bespoke, individualized rehabilitation protocol, which includes the angles that you're happy to go to from week 0 all the way through to probably about week 6 is usually when you sort of don't require any sort of restrictions range of motion-wise, if not a little bit earlier. Again, the surgeon, and depending on what has happened, you need to have the conversation with them and get a clear plan in terms of what you're going to do. And that can be vitally important because you can then incorporate specific ranges of motion using something like this, which is called a CPM, or a continual passive movement machine that is here. So you plug in the exact angles that you want that knee to go to, and you can take them through that journey. So for this individual, this is actually a post-patella rupture that we had. So again, being very specific with the ranges that we go to help prevent any further injury. Other things that you just may need to consider, again, are the individual, and also if this is a redo, so they've injured their ACL and then this has happened again, or it's happened on the other side. You do have to have maybe additional attention to detail, respect it, and think about what you've done on the journey prior, or what somebody has done prior if that ACL goes again, and make sure you don't make the same mistakes. And that sort of leads me on really to the sports psychology and addressing those mental health demands. This is not a easy, straightforward journey on a lot of occasions. It's a significant period out of somebody's career. They may not get back to the level that they were at before. They should do if you rehabilitate them properly. But again, during that journey, there are some pretty significant mental health demands that go on. So you do need to keep touching base and involve a sports psychologist if you need to, a counsellor, whatever they require, and keep touching base with them, not just the physical side of things, but also that mental health side of things. And I think it's important also just to not only address the hamstring, so the focus on your ACL is typically your hamstring because of the fact that it decelerates that leg so importantly. You do need to also, again, think about the soleus, think about the glute and all of those bits, but do not forget about the quad. Your quad, getting that firing early doors will also help with the swelling. And also hopefully reduce any of that quad lag. So that quad lag where you've just got a slight delay in the amount of extension that you have at that knee when you're then extending it in a straight leg raised position. So firing that up, and again thinking about the range of motion that they may have in the knee and where you want to go to. Going actively and being very symptom led is often a little bit safer than you taking them up that way. The other thing that will assist undoubtedly with that quad activation, as well as other muscle groups, is maybe using something like a complex. So these neuromuscular stimulation tools, really useful to fire up the quad, maybe with or without movement itself. And you can use them through the whole journey of that ACL recovery, really, all the way back into different machines, into weight bearing positions, etc. You may find that it just almost from a hypertrophy perspective, or even reducing the amount of atrophy, these are a really useful tool. Now, I'm just going to talk you through a little bit about achieving that knee extension. Now, prior to surgery, ideally you will have restored knee extension and got rid of some of the swelling that's there, so it's in a much better place. This is maybe something you've used prior, or it might be something that you use after they've had surgery.
One of the most important things about the knee is to make sure that they have sufficient knee extension range and that it is symmetrical to the opposite side. If they can't lock out their knee, then they are not going to be able to achieve that screw hole mechanism. So after an injury, or potentially during rehab, if there's been any swelling, irritation, fusions, then they may be a little bit reduced in that range. If they can't achieve full extension range, everything in the posterior knee might be quite tight, gastroc, hamstring tendons, popliteus, etc. To assess the range in the knee, though, what I do is stabilize them proximally, just above the knee. Make sure you're not over the kneecap itself. Cup the calcaneus with your other hand and apply it like a hyperextension force there. Now, I would eyeball to see how far that heel is off the bed, or even use the number of fingers underneath that region to measure where they are. Compare that to the opposite side. If you achieve more on one side compared to the other, ask about the injury history. Is there a reason for that? Are they just stiff? But if they are not achieving full knee extension, they're unlikely to be able to utilize their quads as effectively as they should do. They're probably going to be walking on a slightly flexed knee, and they may end up getting issues on the back of that. If you want to mobilize that and improve the range, depending on how reduced that range is. So let's say that they are coming back after a surgery, for example, there's a lot of swelling, they can't even get their knee to a neutral range. What you might need to do is just add a towel underneath here, let the athlete relax their knee again, and in that position just apply like an AP glide, either side of there or above the knee. Now what that'll do is just start to push that knee into a little bit more extension. Once you've done that, get rid of this, reassess the range, hopefully it's a little bit better. Most people can achieve neutral knee extension, so what you may want to do is almost work on that slight little bit of hyperextension to make sure it matches the opposite side. We don't want to create new range because that's just creating laxity, but what you may opt to do is, again, fold the towel to the necessary level that you want it to be, pop that underneath the heel, and then apply a glide, again, AP direction, down into extension, find the point of resistance, and then just apply a glide or a mobilization into that range. Once you've done that for however long you want to do it, reassess the range again, and hopefully what you've done is achieved a little bit more knee extension, so that knee's in a better place to be more active around the quad and less irritation in the back of that knee. So try that with some of your athletes and see how you go.
So I'm just going to take you through some other ways. Some knees are a little bit more stubborn, or they may respond slightly differently. So here's 3 different ways that you may attempt to increase that knee extension.
So the way that you can increase the amount of knee extension that they have post ACL is maybe to apply a little bit of traction to that knee joint. Potential scar tissue or irritated joint surfaces might be a factor in why it's a little bit limited. So I'd lock that ankle into your side with your elbow, so you're almost squeezing from here. That then allows you in step standing just to lean back slightly. If you put your hands either side of that knee joint, lean back, and then allow that to drop into extension. So you're almost squatting down with them. So find the point that there's a little bit of stiffness, and then almost work on tractioning and then pulling down into more knee extension as you do that. Repeat that for as long as you want to, and then hopefully what you end up with is a little bit more knee extension range when you retest that in this position. So a slight little adaptation to the prone hang is to potentially come into this position. Now, I often find that the hamstring tends to hold on quite a lot more as you start to drop into more extension, particularly if it's trying to protect that knee. Now, what I try to do to eliminate that is almost just pick up and give a little bit of tactile sensory feedback into that hamstring. And then as we drop down, often with that hamstring input, it will allow it to drop into more knee extension. Now, what you might also want to do in that position is almost get them to contract their hamstring very slightly. So you're actually doing like an eccentric hamstring into that outer range there. So if you get them to pull heel to bum, just engaging it, but let me win, so they feel like they've got that on all the time, again, you might find that that actually enables you to take that knee into additional knee extension. You might want to go the other way, so it might be that you actually get them to fire down into your quad. So you push down, engaging quad-wise, so they're almost forcing it into that knee extension range, but they've again got that tactile feedback onto your thigh. So they know that they're supported, they know they're not going anywhere, and if they're not happy, get feedback from them in that position. After you've done that, what I would do is then just reassess that knee extension range with and without that hamstring sensory input. Hopefully that increases it, it works towards that terminal knee extension range, and hopefully from that position, you then end up with a more functional knee. If someone's quite restricted with their extension range at the knee, what you can do is apply a posterior to anterior force to the back of that tibia and fibula. What I've done is created almost like an accelerator pedal. So I've got a Mulligan belt and looped my foot through it from the bottom. So I'm just going to be paddling my foot, and as I go down into plantar flexion, as if I'm pressing the accelerator pedal, that's going to apply a PA force down through that lower limb. Now, what I can do is stabilize them at that level of knee extension that they can comfortably achieve, and then apply a gentle PA in that position. So I'm just pulsing on and off in that position. The alternative is I could apply just a constant pressure down over, and then the other thing that I can do in that position is then add any different forces that I want to apply. With that PA on, I could also go into additional extension.
There you go. So the only thing with the latter one that you see there is you just have to be a little bit careful in terms of when you apply that. That ACL graft that you've got there needs to have matured significantly before you start adding anything particularly above like a grade 2 really to that region. So that might take you 3 or 4 months to get to that level really. Here's another one just with a little bit more traction this time. So again, if you just pull on the ankle, you're probably going to get more hip. But if you counter traction that at the just above the knee region, then what you'll find is that that traction occurs more at that knee rather than at the hip itself. Now you can educate the athlete themselves to do this themselves on their own. So again, you can pop something underneath their heels to put them into a slight bit of hyperextension up to the level that they can achieve. And then they can use something like a power band just to give them a little bit of overpressure with that. So by leaning backwards, they then pull that knee into slightly more extension. And on the right hand side here, you can see one of our Fijian second rows actually going through the same thing, a guy who had stirred up joint related issues and basically getting exactly that same masterclass of treatment live. This is slightly different. So rather than using maybe your own hands to create that same amount of glide, if you've got a really large athlete or you want to free your hands up, you can use one of these Mulligan belts, and I'll show you this now.
So if we want to try and increase the hyperextension or that terminal extension of that knee, what we can use is something like this Mulligan belt. So this, with body weight, can obviously prevent you having to lift this leg up all the time, and also gives you a little bit more chance to stabilize what's happening up here, or even give you a free hand to glide in either direction. So in that position, what we're doing is taking it to his available range, and then what we can either do is add a glide down into that position, or we can stand up a little bit more, so we almost increase the amount of extension from the distal end. So your options are either take it to their available range and add a glide above the level of that knee, or stabilize the knee here and then apply a glide up over in this position. which again starts to increase that terminal end range knee extension that they have there. Typical things that are lost after meniscals, ACL, ops, etc.
And the other way you can get them to reinforce that, to try and encourage an active extension, is to do some reduced body weight extensions at the knee. Now, you can do this in loads of different ways, and a lot of this is going to be in that rehab module for that ACL. But you can see just using something like a band to encourage that extension and work into that terminal range might actually make the athlete a little bit happier working towards that extension and that sort of almost screw home position there. Now, what can happen is you end up with some patellofemoral issues. Now, if you've had a patellar tendon graft, you almost certainly end up with a vulnerability to having more anterior knee pain. However, if you haven't had knee extension, you can do this on yourself. If you cannot achieve terminal knee extension, your patella is going to become a little bit sticky, a bit gummed up, and it's not going to mobilize very well. So you could treat your glutes and get them fired up till the cows come home, chuck as many orthotics as you want into the shoes or boots or whatever. But if someone is not achieving the sufficient amount of knee extension and then has sufficient patellar mobility because it can't sit in that trochlear groove very nicely and move, then you are going to get patellofemoral issues because the back of that kneecap is going to rub and stir up the surfaces and become quite painful. Now, this is almost a certainty that you're going to need to do this after you've restored that knee extension. There's not a great deal of point for me in doing much of this until you get to around neutral range because it just won't move. But once you get there, addressing that patellar mobility is really important. Now, the majority of the time, it sort of sits almost stuck down laterally, so there's almost reduced medial glide of that kneecap, but you also need to think about whether it's tilting like a little seesaw or if there's any rotational components with that. And once you get that moving, what you might opt to do is maybe encourage that VMO to fire a little bit more, maybe even tape it in a slightly more optimal position, just so it doesn't fall back into that lateral glide or lateral tilt position really. But we cover a lot more of how to do that within the patellofemoral module. Now, ideally during your rehabilitation, you've addressed all the strength components that have occurred, but what can sometimes happen is when you introduce a bit of running or loading, or you're starting to get plyometrics going or high speed things going, again, a little bit of maintenance through that medial hamstring and that adductor complex is not the end of the world. Sometimes people require it. It just becomes a little bit worked, if you like, rather than sort of overloaded. But yeah, just by the periods you go through where you are a bit more intense as you're ramping things up, you may well find that there's a little bit of tension tautness that goes on through there. If you are getting a significant amount of pain in your groin, or you are finding that hamstring is really gripping on for dear life, it's probably because you haven't addressed the stiffness, the strength components, or the capacity of that soft tissue complex. And there's lots of different ways that you can address this. This is some of the sort of more neural techniques. So you're kind of almost doing like a passive neural glider in that position, going up into hip flexion, then into knee extension, which obviously starts to bias that sciatic nerve. Thinking about, obviously, if you've had a graft, potentially you're going to have scar tissue through that region. You might have little bits of tethering between the sciatic nerve and the hamstring tissue that's there anywhere from that proximal to distal aspect. So again, you might need to look at the interfaces or if there's any sort of frictions or scar tissue that may need breaking down there. And then once you've broken it down, really reinforcing that with some of your neural gliding techniques. The other things that can also get a little bit tight and need a little bit of care are the sort of lateral quad and IT band. Often feel like they're a little bit stuck together. So sometimes grasping in along that line, sometimes using sort of negative pressure like a lymphatouch, for example. Maybe other TECAR therapies and things to try and almost prise them apart if you want to kind of term it that way. But it can certainly, that lateral quad, really, really important in terms of its function. But if it gets a little bit overworked and there's not enough hamstring, that may well also be an indicator that you maybe need to address some of that deceleration and strength capacity in the hamstring. Now, you've also got flexion, which requires work. Now, extension is far more important to get back early doors from function perspectives, etc. But actually, if you later on during the running, for example, realize that they maybe have a little bit reduction of knee flexion, then again, functionally, when they get up to the high-speed meters, if their heel flick isn't as high, whatever it may be, you may need to work into that terminal range in order to restore that so they don't have issues. Now, there's lots of different ways that you can do it, and you can also apply mulligan glides to try and improve that range as well. So you can test it a little bit. You can apply a lateral glide to that femur, medial glide to the tibia. You can even kind of alter your hands around a little bit and sort of play around with things. So again, different variations that you might find actually encourage a little bit more range flexion wise, but what you're doing is gradually in a reduced body weight position potentially to start with, working through that available range, working into the end of range. You might want to stop terminal range and do some specific moves there. If you find that actually there is a way or a preference that it prefers, you may want to tape that into position. I've just done this over my trousers so I don't get the irritation from the glue, but obviously I'd put that directly onto the skin and reinforce it. And then what you can do then is almost use your weight pressure over the top, either with your hands or with a dumbbell or something, or a kettlebell over the top of that thigh to add a little bit of overpressure into that end range. You can do other things as well to assist you. So you could use that mulligan belt again for other components like this. So you can apply the glide in different ways. You can maybe lean into it to get an additional amount of sort of traction, and that might be that you get a better response by applying that medial to lateral glide over the femur, but it might also be in that tibia. Everybody's different. Play around with it, see what works best, and basically you're just going to do a bit of a trial and error thing, whatever it requires in order to get better range. And once you've got that, you might want to take that into a weight bearing position and do exactly the same thing to try and reinforce that normal bend. Now, your hamstrings may be protective, and that's, again, usually because the strength is not there. So, again, test it in different ranges. Do look at the neurodynamic components on a straight leg raise and a slump. Think about all your different variations of biases. So your sciatic nerve is biased more with medial rotation. It's biased more with adduction. It's biased more with dorsiflexion. It is biased even more with cervical flexion. So, again, you're going to piece all these things together to work out where potentially you are picking up the most tension in that neural system, and then focus your attention in and around that area. Some of the retraining elements that come with that, again, thinking about co-contractions of quads, hamstrings, and again, the relationships, particularly again, of that soleus, your medial hamstring, and your glutes. And these are just a couple of examples of different sort of flossing techniques that you may give your athletes to do themselves. Again, thinking if you've got that hip component proximally wound up and then working off it with the knee, where is picking up the most tension? You've preloaded that hip proximally initially, but you can also do that and do an active straight leg raises that you can see on the right hand side there. And you can also add abductions, adductions, again, just to add and take off a little bit of glide around that region. Think about using bands if you need to around feet to add a bit of overpressure, and basically piece the whole thing together. Now, when somebody goes back into something that's a bit more competitive, you're hopefully going to have ticked up everything in a gym environment and then running and then almost gradually prepared them. What you may benefit from sometimes is some strapping around that ACL. That will give it some additional sensory input. It may make the athlete feel a little bit more confident, make you feel a bit more confident about what's going on. So I'm just going to show you how you may apply an ACL strapping. This is what I would use, and then I'll show you sort of an adapted version after that.
So let's run through an ACL strapping. Main intentions with this is really to stop that anterior tibial translation occurring and also that torsional rotation that occurs. Obviously, we want to try and support the MCL because that's typically injured. Thinking about, again, meniscal injuries and how the rotational components can influence that. So we're going to put a couple of strips straight vertical, and then we're going to basically apply an anterior to posterior glide from that tibia to that femur. So on the medial aspect, we'll put our anchors on as standard. Give yourself enough space, depending on the size of the athlete. Exactly the same below. So we're just going top to bottom, straight over that MCL really. So fixating here. And then what we're doing is we're going from really an anterior position just to a posterior position. I don't go from that posterior aspect to the anterior because in theory that's drawing forward that tibia. So measure up. Fixate distally and then just apply that pull to a proximal aspect there. Exactly the same. Either use 2 or 3, depending on the size of the athlete and how much stability that you're after. Lovely. And then you're just going to apply those anchors back into that position just to fixate everything together. You're going to apply exactly the same on the lateral aspect. So if I can get you just to swivel round. Extend your anchors. If you need to use some adhesive spray, do so. And exactly the same, we're just going to go straight down the line of that LCL, then we're going to go from an anterior to a posterior direction. And that is your base layer there. After that, just grab a hold of something like a tail light or a muller strapping. And what you're going to do is a figure of 8 in that position. So if you nudge back a little bit. Start medially. Lay this on just to make sure that you aren't doing anything that's going to occlude. And then just finish laterally. If you want to finish off with a bit of zinc on the outside, you can do. You could use electrician's tape. And just finish that off. So that really is giving that prevention of that anterior tibial translation, rotational components, and then everything locked in for a bit of stability.
So there you go. So that's how I would do it. The other way you can do it, and I've just sped this up really, just to give you a little bit of an indicator, is sticking the anchors on and only applying around that patella, really, again, from a sort of lateral to medial position, and then a medial to lateral position. So you're going round the patella, and then almost again, figure eighting your way forward. That is a sort of more simple approach to it that way. Now, the other thing that you may require, if there is significant swelling that you aren't budging or there's re-irritation, particularly, the only ones we've seen with this are sort of the ones who've had meniscal repairs and just keep stirring it up. You may need drainage. You may also look at possible cortisone injections, like the anti-inflammatory components. And then also these things like your hyaluronic acid injections. So Ostenal or Ostenal Plus are the ones that we would use. And again, what it acts as is something like this. It's almost like a lubricant across that surface, so it helps protect that articular cartilage that's there. So almost, again, from a looking after the surfaces perspective, maybe something, if that's quite stirred up or there's underlying grumbles, arthritic changes that have maybe occurred that are vulnerable to flaring, sometimes these ostenyls over the course of a season may well help to give that athlete a little bit more comfort, mobility, and help you get through some of the more stubborn times during your rehab. The other little components just to think about that we touched on in the assessment part are the different surfaces. So you may need to intervene and give some education advice to the athletes, to the coaches about maybe the restrictions that this individual may require. I know some individuals, again, in Prem Rugby, they had contracts to say that they could not play on artificial surfaces due to the increased risk associated with their injury types, not always to do with ACLs, but more to do with sort of underlying meniscal issues and that flaring up. And the other things are thinking about the sort of footwear advice, guidance-wise on that. So it's moving from something like a blade, which doesn't allow rotation and there's a bit more traction, to something that is going to allow you a little bit of an option to pivot, so there's a bit more give in the system. And that's it, really. So just in summary, really, I know we've talked about quite a lot of different areas, but surgery is clearly a vital part for a lot of athletes, maybe not all athletes, depending on what they're going to go back to, the stages of their careers. But I would say anyone who's going back to cutting, stepping, unpredictability levels or elite sport that is going to put them in a vulnerable position, I think ACL surgery is pretty essential to avoid recurrence. Early management is really important, and that includes some of the pre-op work that you do. So if someone has injured their ACL, that isn't a time just to wait and see what happens. Get on top of swelling, get their range of motion back, use some of those extension-related techniques that we showed you manual therapy-wise. And then on the other side of that, wound and scar care management, again, scar massage, desensitization. There may be associated reductions in sensation, particularly in those infrapatellar branches that occur under that patella when they've gone in with the scope. That may not come back, but again, it may be hypersensitive. There might be allodynia stuff going on. So again, more input with that, the better, to desensitize it. Use different textures, silks, little roughened things, hands, massaging, whatever it is, once that scar has sufficiently healed, so there's no disease or germs or anything that's going to get into, is really important as well. Don't forget about the quads. There is a massive bias through the whole hamstring region because of the deceleration properties, but obviously the absorption through that knee comes from quads, and also making sure that we get that end range knee extension, really important. You will be in a brace, or that individual will be in a brace for a certain period, so you do need to follow the angles quite specifically. They're quite easy to adjust if you've ever used one before. We used the Don Joy ones that were really, really good, because you could quite simply alter the angles of flexion and extension according to that protocol, and do, again, restore that knee extension from an injury prevention perspective and secondary injury perspective. And again, thinking about what has happened. So when they've had their operation or they've used that hamstring graft, there are implications that they are going to be less mobile. So they may be a bit more vulnerable to neurodynamic related problems as well. And you just need to address them. Think about all the manual therapy, flossing, gliding techniques that you may use. And it is not an absolute no-no that manual therapy doesn't have a role. If you are getting tight or a little bit stiff, just help that athlete through that journey. If it keeps on happening, obviously you need to kind of work out why and look at all your force plates and strength outputs in certain ranges. If you have associated injuries, again, this may not be a linear sort of build-up ACL-wise, and you do need to respect particularly any meniscal injuries and particularly any bony bruising that can come back to haunt you a little bit. That stuff does linger. But that is it, guys. Well done. Congratulations. That is the ACL treatments and interventions complete. I hope you've enjoyed it, taken loads of take-home messages. Obviously, on growphysio.com, there are loads more of these educational adventures, if you like, that you can go on. There's a lot of information that's available on at growphysio. At grow.physio, on Instagram. Contact me on Twitters if you want to, or fire off an email to sort of steve@growphysio.com. but it's been great sharing with you some of the techniques that I've used. I hope you found it really useful, and I really hope you use the platform and obviously join the Grow Physio family.
Okie dokie, folks. We'll end it there. It seems a bit old, doesn't it, that now? The Twitter references and the website's also changed to Grow Physio Academy now, so it's much more of like a complete learning experience. But yeah, I hope there's lots of things there that you guys found useful. Thanks for sticking with it on one of the few super sunny days in the UK. You might well be watching this outside. I got a few of the answers actually, guys, for some of the questions that came in. So one of the questions was around hyperextension and how many injuries come from hyperextension. Now, there's not really a great deal of evidence from looking out there of what percentage of ACL ruptures are from a hyperextension. It just isn't out there. But what they have found is that actually, and we found this in practice as well, that if the ACL graft repair wasn't particularly tight and it had excessive amounts of hyperextension, they have a higher failure rate. So there's a higher re-rupture rate if you've got quite a loose graft that's there. So we've actually had some in the past. I remember a skateboarder in particular, who was high-level skateboarder. He had his ACL rupture, had it repaired, and he had just had excessive amounts of laxity in it. So he actually went back in and got it re-tightened up again. So yeah, if there's sort of an excessive amount of hyperextension, they're saying sort of anywhere from about 5 to more than 6.5 degrees worth of hyperextension. That's a little bit of a risk factor. So when you're working on restoring that normal knee extension, don't feel like you've got to force it to make it exactly the same as the other side. If it's lacking terminal extension, then obviously kind of nudge it, work on the soft tissues, try and encourage more range. You shouldn't be running around on a bent knee, but don't feel like you've got to really push it. In terms of isolated ACLs, they're reckoning in the literature about 20% are isolated, 80% come with some sort of other pathology, most typically meniscal from that. And then that Lely test that we sort of talked about earlier on, so it's quite a newish revelation, probably in the last few years. It's kind of become a bit more popular, where you're sort of popping your fist underneath and trying to look to see if there's any sort of obvious signs of ACL actively. That originally had a sensitivity of 100%, which is pretty damn good, but then subsequently it's around 63 to 80 something percent sensitivity. So yeah, not bad though, to be fair. Good in those acute phases is what it's saying. Now we'll get to the questions now. So we've got Oscar: is scar contracture quite common post-surgery? I don't think it's ever been an issue for us, but obviously we kind of get on top of them quite quickly. Now, some of the ACLs that came that were performed maybe just before lockdown and COVID, that didn't get the access to physiotherapy and didn't really go through a proper rehab journey, they often had more issues with that scar contracture and not restoring some of that kind of early mobility and movement and being given that kind of all clear and confidence to move. So we had a real tricky one in judo that basically we didn't get a hold of very early and then really paid the price for that later on. When a player has a suspected ACL injury in a game, is it best to put them in a knee brace straight away? And what angle should the restriction be set at? I think what you don't want to happen, and it's a really good question, what you don't want to happen is that knee collapses, and then because it hasn't got the stability, and then you get some sort of secondary injury, or you maybe go from a partial to a full injury. It doesn't take much. Sometimes people will slip on the changing room floor. They might just be walking and stand on something that's not particularly stable, miss a curb, whatever it is. And if they haven't got the stability from their ACL anymore, I would pop it in there, and I would put it in just a slightly flexed position. I think we used to put them in about 10 degrees and almost kind of have that on. If they've got a decent brace, you can allow them to bend and flex that knee. It's usually the movement that's in that kind of transverse plane or rotational sort of plane that causes the issue. So yeah, normally would allow them to have a reasonable bit of flexion, usually maybe sort of 70% up to about 10 degrees of extension. So that would be my advice, just to stop them having anything. Has anyone got any other questions that you want to ask? I'm very happy to answer anything around ACLs, or if there's anything, any other interesting cases you guys have that you want to share, I'd love to hear them. Deathly silence. Feel free to drop your microphone on if anyone wants to ask any questions. It's a good opportunity to kind of reach out if you want to. If not, just while people are building up courage, then, or asking questions, then yeah, I'll get the recording uploaded straight after this. And then I'll send you guys it through, and then it'll come with your certificates. If you're keen to come and watch the rehab side of things, that's on next Wednesday at the same time. So have a little look on Eventbrite, and we'll go through the rehab. Again, loads of videos of the athlete going through their journey, lots of late stage ideas if you want to kind of get involved with some of those. Trying to just match the demands really of whatever people are going back into in rehab. So it does have quite a few nice creative ideas that sometimes you just don't think of unless you've seen someone else do it, and you kind of go, oh, that really makes sense. I'll nick that and then apply it into my own practice and see how it goes. That's fine, Oscar, if you want to stick around, that's okay with me. I can't guarantee that everyone else will go, but yeah, feel free to ask anything if you want. It's fine. So yeah, just lastly then, I guess no more questions kind of coming in, but if you are keen on sort of delving into this really exciting world of kind of MSK and sports injuries, and it's something that you're really interested in doing, but you maybe don't feel like you've necessarily got all the tools or skills to do it, then I do think this sort of platform is perfect to kind of bridge that gap, so you don't go in just feeling completely out your depth. I know when I went in originally, there was a massive gulf. Even though I'd worked for probably about 6 or 7 years in part-time rugby, it's very different to full-time sport. You kind of carry with you a bit of an NHS mentality, maybe private practice mentality, but there is a really nice beneficial sort of side to working in sport where you've got access to individual players much more frequently. You can be much better at kind of progressing and regressing your rehab and getting hands-on and using treatment techniques and sort of actually making a real positive difference in these athletes. So it's something I really recommend. Get someone who's going to kind of take you under their wing, help you, guide you through that, would be my advice. If you are going to volunteer a little bit, that's fine. Just make sure that you're getting plenty of kind of growth opportunities out of there. And yeah, hopefully the platform sort of helps you on that journey. Bro, just a few thank yous coming in. You're very welcome, guys. Thank you all so much for giving up on hump day. I know it's not easy getting through Wednesdays, but fair play to you for sticking in. Hope you all enjoyed it. And if you've got any questions after, then obviously, guys, just reach out to me. I do teach. I'm teaching all day tomorrow, but I'll get back to you as soon as I possibly can.